This is Catherine Dow reporting for RheumNow Live 2019 here in Fort Worth, and I have one of the most famous shoulder surgeons with me, Dr. Buzz Burkhead, who just gave us a very interesting, exciting, and art-filled lecture. One of the things that you don't know about Dr. Burkhead is he's an art aficionado and also a musician. Tell us about yourself.
Well, I grew up art, and I went to college to be a commercial artist, but I lacked talent, and I decided to do something to help people, and I became a doctor. But it's dovetailed well. I draw things for my patients, and I designed a shoulder replacement on a flight from Dallas to Austin, Texas, with drawings. So I'm not an engineer, but I can communicate. And art's something you can do all your life. Then I have a music hobby. I have a couple of bands. The one that does my original music is Dr. Buzz and the Medicated Trio, and sometimes they're heavily medicated when they play. But I've got some original songs out there, about 4 CDs of original music. So it's a lot of fun. And then I'm a shoulder surgeon in Dallas, Texas, is my day gig, and everyone tells me I shouldn't give up my day job.
Now, one of the things that rheumatologists really are terrible at is the shoulder exam, because we have patients who come in and they hurt in their shoulders. And first thing that we do is we'll mash on it a little bit, we'll move it, but all these maneuvers that you described in your lecture, we're not that good. And so we send them for imaging, and typically it's an MRI, and if we can't figure it out, we send them to you. Can you show our audience the best way for rheumatologists to examine the shoulder in order to identify pathology? And what I'll do is I'll hold the microphone next to your mouth while you demonstrate the shoulder exam on me.
Okay. So I'll do the left shoulder, and basically one of the most important things to do is to take a history, obviously first, the most important. So you get a historical aspect, so you want to know when the pain started, how intense it is it worse at night, what makes it worse? Simple questions that you learned in medical school to ask, but the answers are important. So if their pain is more when they move their neck back and forth, then it more likely than not could be coming from their neck. If it's more when they move their arm up and down or out, then it's more likely their shoulder. The first motion to go in the shoulder with most shoulder conditions, whether it's arthritis or frozen shoulder, which is again very common, is internal rotation up the back. So what I'll have you do is just turn towards this way.
Okay, I'll hold it.
Okay, and then just reach up. Well, that's going to be elevation. So okay. You were right. Rheumatologists suck at this. So go do what I want you to do. I'll show you what I want you to do. I want you to do this, and sometimes you have to do this with the patient. I want you to go up, and I want you to take your thumb. And so we measure this motion where the thumb goes to the spinous process. So the lower border of the scapula is about T9, T10. So on this exam, you go to about T11 or T12. And some patients are so flexible they can bring their hands up even higher. So you can see I thought she'd be more flexible than that. So now you can turn back towards the camera. And maybe I'll hold the microphone, because one of the things, you can't just examine one shoulder. The good thing is orthopedic surgeons aren't that smart, so the good thing is patients have two shoulders, so we can look, pretty easily see the difference. So the simplest maneuver that usually is not too painful for a patient is to just simply elevate your arms. So raise both arms up for me like that. So this is forward elevation, and that's a very functional motion. That's how you would reach for a plate. That's how you reach for things. Now let your arms come down to the side. Okay, abduction is bringing the arm away from the midline like that, and do that with both arms. That's not as important a motion for function, but it's something that we do measure, and something that patients always ask about. It is say, it hurts when I do this, doctor. Well, sometimes it is better to go ahead and just say, don't do that, because in that position with your arm internally rotated, you're putting a lot of pressure on your rotator cuff, and you're increasing the joint reaction force. External rotation at the side is the next thing we look for. So we bend the elbow here, and then we rotate the arm out. And a woman like Catherine will have, in her case, 70 or 80, maybe even 90 degrees of external rotation. Patients that are ligaminously lax or have Ehlers-Danlos, they'll have 100, 110 degrees sometimes of external rotation side. The next thing we'll do is just some simple strength testing. And classically, the rotator cuff, if you look at how to test the supraspinatus, we'll put the thumbs down with the arms in pretty much scaption, so having the arm lined up with the spine of the scapula, and then we'll just press down. And she's got great strength there, great strength there. Again, you got to look at both sides, and you got to make sure whether they're having pain or not, because again, there's a lot of neurogenic reflex inhibition of muscle function in the shoulder. Bring your arms back down to the side. So that's the supraspinatus. Next, we're going to test the infraspinatus. So we're going to have you rotate out against my hand, and don't let me push you in. Good. Now, internal rotation tests the subscap, but it also tests a lot of other muscles like the pectoralis major, the latissimus dorsi. So one of the specific tests that we do for subscapularis function, we call it the belly press test. So I'm going to ask you to put both hands on your abdomen and then bring both elbows out like this. And so if you have a subscap tear, relax this arm, then that exam, bring this one all the way out like you did before, that exam would look like this. This would be a positive belly press test on your left shoulder. The other test that we see that we use for subscap function, because it's the terminal amount of internal rotation, is called the Liftoff Test. And so turn this way, and now bring your arm back up here, and we're going to just ask you to lift your hand up off the spine. So that's a great test for subscapularis strength. The external rotation, that you're testing both the infraspinatus and the teres minor. If you want to test the teres minor specifically all by itself, bring the arm in abduction, and now I'm going to have you rotate your arm like this. So it's an external rotator, but it works up, and this becomes important when we look at patients for reverse shoulder replacement, because if they have a good teres minor and they can do this, then oftentimes they'll get enough functional external rotation where we don't have to do a latissimus dorsi transfer to restore their external rotation. Palpation around the shoulder, we look at the AC joint, the coracoid process. Codman's point is where the supraspinatus inserts. The biceps tendon is found just right here with the arm in about 10 degrees of internal rotation. It should be straightforward. And the thing, I'll let you hold this now. I call this the tenderness in motion sign, where I put my finger here, and if they have pain there, and I rotate the arm in, and the pain goes away, then comes back, the pain is there, rotate it farther out, the pain goes away, then that's specific for the biceps, because the biceps is going to rotate with the humerus. And if you just have tenderness here and it doesn't change, it's usually coming from the subacromial bursa. So specific maneuvers for things like the AC joint, we bring the arm way across in cross-body adduction. That causes discomfort here. Going up the back loads the AC joint, and then a maneuver that we call the impingement reinforcement sign of just having the arm in about 80 degrees of abduction and then internally rotating. That also will generate pain that's coming specifically from the AC joint. We always want to look for discrepancies between active and passive motion. Patients who come in with really severe osteoarthritis or frozen shoulder, their active motion and their passive motion will be about the same. So we could rotate the arm out to about here, it would just stop dead, and then the patient could only rotate their arm out like that. If their passive motion is full, but then we test them and they can only actively rotate to here, or we take them out there and their arm just flops back in, then we know that they have a rotator cuff tear or an injury to the nerve. And the other things that can look just like this, and this is why you've got to go through not only the shoulder exam, but the neck exam, is a C5-6 radiculopathy can present the same way, with a lot of weakness in external rotation, a lot of pain on the trapezius ridge. And those patients, usually if you ask them which hurts more, moving your arm or moving your neck, they'll tell you it's their neck. So a good neurologic examination should also be part of the comprehensive shoulder exam. Speeds test is another test for the biceps. You have the arm straight out, palm up, we push down. That'll give you pain down your biceps. It also tests the anterior part of the the supraspinatus. And then the other test that's commonly done for the biceps is Jurgis Ins Test. We're going to have the patient concentrate on pain they have right there. We're going to have her supinate her arm and then try to resist and pull up at the same time. So it's flexion and supination at the same time with referred pain to the biceps. That would be a positive Jurgis Ins test. Slap lesions, I use the O'Brien's test. Again, we have the arm out here. We're going to put the thumb all the way down, but in a flexed position. We're going to push down And if the patient has pain in that position, and then we put the arm up, they don't have pain in this position, then that isolates it to either the labrum, superior labrum, or the AC joint. So when we're doing this part, we kind of repeat this one again and say, now I want you to concentrate and tell me, do you feel the pain deep inside your shoulder or up on top of the shoulder? When we push down in this area, if they feel it up on top, that's more of the AC joint. They feel it deep inside, that's pretty typical, about a 94% specificity for a slap tear.
Well, there you have it. That's Shoulder Exam in 5 minutes by Dr. Buzz Burkhead. Thank you so much for your time here at RheumNow Live.
Thank you. Thank you for having me.